Good morning. It's our second fellow presentation, right? So Tarek or Dr. Chami is an interventional cardiology fellow, also successfully got a job, and I see it's the First Coast Cardiovascular Institute in Jacksonville, Florida. Congratulations,
Thank
exciting.
You. Thank you.
When are you starting?
July 1st.
July 1st. All right, no vacation. Maddie and him are the second year, as I said last time, of two fellows. And they are both doing an exciting job, and we're so happy that we have, so many good fellows now in the cath lab. Tarek joined us. When did you actually interview? It's always interesting. It's like many years ago, right? Because we have always
before COVID.
Yeah, before COVID. So because we have always a 2-year lag almost for interventional fellows. Yeah. They barely make it into the cardiology fellowship, and then they already have to interview for interventional cardiology. That's how it goes. And then they come up here and to different people. Anyway, he came from Case Western Reserve University, Cleveland, Ohio. And I saw that you published almost 30 papers and added some here while you were here. That's great. Yeah. And today, I'm not sure about this talk, but if you want to really engage in that.
Yeah, the interventional people.
Yeah. Invasive coronary disease, it's coronary angiogram versus the computed tomography, and I think sometimes we struggle with that every day. It depends on the patient, so hopefully we'll learn something. I'm sure we will.
I hope so.
And congrats again to your job.
Thank you, Dr. Gassel. Good morning, everyone, and thank you for being here for the ground rounds. Thank you again, Dr. Gassel, for this kind of introduction. As I was preparing for this talk, I wanted to choose something more appealing to a greater audience than interventional cardiologists. And I thought that will be an interest to some of us, and also some of us who receive on the other end in the cath lab. So as I was preparing for this talk, I got to realize that it's actually not a comparison between invasive angiogram and coronary CTA, rather than it's a supplement of what we do in the cath lab. So a better title would be a complementary role of coronary CTA in patient with a CAD. I will focus more on these particular set group because there's a new emerging data. So I have no relevant disclosure except that I'm a plumber interested in the intersection between non-invasive and invasive imaging. My objectives for the talk today is to review the utility of coronary CTA in patient with chest pain and explore the emerging roles for coronary CTA in patient with non-ST elevation acute coronary syndrome and patient with known CAD. I will start with a case that will illustrate a few points that I will discuss during my talk today. This is a 77-year-old man with coronary artery disease who underwent 2-vessel bypass, lima to LAD, venous graft to OM, and had a bioprosthetic AVR at the same time with 25 millimeter Inspiris valve, almost 2 years prior to his presentation. He was referred to our cath lab for dyspnea and exertion, which was his angina equivalent, and he had an abnormal coronary CTA. His other past medical history and past surgical history were pertinent for recent stroke. That was 2 months prior when he presented with left upper extremity weakness, dizziness, also peripheral arterial disease, hypertension, dyslipidemia, and history of tobacco use disorder. His coronary CTA showed atretic lima to LAD. The graft to the OM was patent. There were obstructive native multivessel disease with occlusion of the proximal circ, severe stenosis in the ramus intermediate, and more than 70% stenosis in the proximal RCA. Actually, the reader of the coronary CTA compared the CTA to a prior coronary angiogram that was performed prior to his CABG and AVR, and the catch was that the proximal RCA disease appeared more severe. This is a coronary CTA picture showing severe proximal RCA disease. And this is his coronary angiogram in the RIO projection showing severe proximal disease. And this is after stent implantation with successful angiography results. So as we all know, heart catheterization has low diagnostic yield for obstructive CAD in patient with not known CAD. This was illustrated in this study from the NCDR database. Patient who underwent diagnostic CAD between 2004 and 2008 were enrolled in this study. They excluded patients who had known CAD and those who had urgent or emergent CAD procedure. After exclusion of these two set of groups, they ended up with almost 400,000 patients. Of those, 83.9 had non-invasive testing prior to her heart catheterization, but only 37.6 had obstructive coronary artery disease at catheterization. Also, heart catheterization is an invasive procedure, is associated with adverse cardiovascular events. From the CORE 320 study, in a total of 381 patients, within 30 days following invasive coronary angiogram, 2 patients had myocardial infarction, 2 patients had coronary dissection, 1 patient had femoral artery pseudoaneurysm, and 1 patient had intracerebral bleeding. On the other end, coronary computed tomography angiography is a powerful clinical tool that can be used to detect and characterize the coronary artery disease across various stages, from early subclinical disease to plaque formation, progression, and rupture, and finally, myocardial infarction. The present results from the accuracy trial that provide the first prospective multi-center data evaluating 64 slice coronary CTA compared with the QCA in symptomatic individual with not known CAD and intermediate intermediate disease prevalence. Coronary CTA demonstrate high accuracy for detection of obstructive coronary artery disease. More importantly, the negative predictive value was 99%, which firmly established coronary CTA as an efficient, non-invasive method to rule out obstructive CAD. And a 2018 meta-analysis that compared several non-invasive diagnostic modalities about their diagnostic performance to rule out significant CAD in patients with angina as compared to invasive coronary angiogram and invasive FFR as the gold standard. Coronary CTA emerged as the best modality with a pool sensitivity of 97% in detecting anatomically significant CAD and pool sensitivity of 93% in detecting functionally significant CAD, albeit at the expense of poor specificity, 78% and 53%, respectively. Not just that, coronary CTA can identify atherosclerotic lesions that are associated with subsequent development of acute coronary syndrome. In a study of 1,059 patients who underwent coronary CTA, atherosclerotic lesions were analyzed for the presence of 2 features: positive remodeling or the low attenuation plaque. And they found that there was a significantly higher likelihood of acute coronary syndrome in patients with 2 feature positive plaque or 1 feature positive plaque as compared with 2 feature negative plaques or no plaques, 22.2%, 3.7%, and 0.49%, respectively. So what is the clinical effectiveness of coronary CTA? In this meta-analysis in 2017 that was published in JAMA Internal Medicine, which included 13 trials with almost more than 10,000 patients in the coronary CTA arm and 9,800 in the functional stress test arm. Coronary CTA was associated with increase in the invasive coronary angiogram, revascularization procedure, and a new diagnosis of coronary artery disease overall and in both acute and stable chest pain. Also, coronary CTA was associated with increase in aspirin, statin prescription overall and in patient with stable chest pain but not those with acute chest pain. Also, coronary CTA was associated with the decrease of incidence of myocardial infarction overall and in patient with stable chest pain but not those with acute chest pain. Furthermore, coronary CTA maintained clinical effectiveness over standard of care in the long term. This is from the Scott Hart trial. The primary long-term endpoint, which was a composite of death from coronary heart disease or non-fatal MI, was significantly lower in the CTA group than in the standard care group, 2.3% versus 3.9%. This was primarily driven by lower rate of myocardial infarction in the CTA group than in the standard care group. Although the rate of invasive coronary angiogram and revascularization procedure were higher in the CTA group than in the standard care group in the first few months, however, overall the rates at 5 years were similar. This was interesting and on the contrary of the previous meta-analysis, suggesting that the benefit of coronary CTA may be about clarifying the CAD diagnosis and subsequent implementation of preventive treatment and preventing spontaneous myocardial infarction. The prognostic power of normal coronary CTA was assessed recently in a study of 2011 patients with suspected but previously diagnosed coronary artery disease who underwent coronary CTA. The mean follow-up was 10 years. The annual event rate was 0.04 in patients with normal coronary on baseline coronary CTA. The highest annual event rate was 1.33, and that was found in patients with 3-vessel obstructive CAD. So they concluded that patients with normal coronary CTA benefited from event-free survival period of 10 years against cardiac death and myocardial infarction. So pretty powerful. What does the guidelines tell us? The most recent guidelines have endorsed the use of coronary CTA as a first-line imaging modality in evaluating patients with chest pain since the 2019 in the European guidelines. The caveat limitation to coronary CTA is extensive coronary calcification, irregular heart rate, significant obesity, and inability to cooperate with breath hold commands. What about our guidelines? The 2021 ACC/AHA chest pain guidelines gave Class 1A to coronary CTA as initial test in patients with intermediate risk who present with acute chest pain with no known CAD and no previous diagnostic evaluation. And Class 2A for those with inconclusive or mildly abnormal stress test. Also Class 2A in those with known non-obstructive CAD, which was defined as less than 50% stenosis. So moving on more recent data, lately there have been emerging data about the role of coronary CTA, particularly in patients with non-ST elevation acute coronary syndrome, patients with known CAD, which include patients with prior CABG, prior stent, CTO, and multi-vessels. In the era of high sensitivity troponin, it is important to remember that the detection of troponin is not just an indicator of ischemic injury. It is a myocardial injury. From the Sweetheart Registry, which is a nationwide registry which includes almost all patients who were admitted to the coronary care unit or other facility because of symptoms suggestive of acute coronary syndrome, in patients with only minor increase in troponin, which was defined in this study 14 to 49 nanogram per liter, i.e. a group of which most patients would have had negative results by older troponin assay, almost 30% have normal or non-conclusive coronary angiogram. So with that in mind, it is apparent that a more sophisticated approach act as a gatekeeper for invasive coronary angiography would be warranted to minimize the procedural risk, lessen the exposure to unnecessarily antithrombotic and subsequent bleeding event, and maximize the benefit for patient who needs an invasive approach. So the Carmenta trial was set to evaluate non-invasive imaging first in low-risk NSTEMI. This was a prospective, open-label, single-center, and randomized control with CMR or CTA as initial strategy versus standard of care. Implementation of CTR or CMR as an initial first test reduced the proportion of patients who were referred to invasive coronary angiography during their initial hospitalization, 66%, 87%, versus the standard of care, which was 100% referral to invasive direct coronary angiography. Significantly lower invasive coronary angiography was performed in the CTA first than in the CMI first group. Rate of obstructive CAD was 61% in the direct referral, 69% in the CMR first group, and 85% in the coronary CTA first group. The composite rates of MACE and procedure-related complication were non-statistically significant, although numerically higher in the standard care group, 23%, 19%, and 16% respectively. The diagnostic accuracy of coronary CTA in patients with non-ST elevation acute coronary syndrome was recently assessed in 1,023 patients with non-ST elevation acute coronary syndrome and were thought to be in the low-risk category. They underwent coronary CTA as well as invasive coronary angiogram in the Verdict trial. Per patient, the negative predictive value of coronary CTA for obstructive CAD was 90.9%. As you remember, the negative predictive value in a stable disease is 99%. The positive predictive value, sensitivity and specificity were 87.9%, 96.5%, and 72.4%. So this performance was similar to that of CTA in stable disease in terms of sensitivity and specificity, 97%, reported sensitivity 97%, and 78%. Whereas the negative predictive value is lower with the 90%, and that might be related to the prevalence of obstructive CAD in this patient population. The rapid CDA trial tested if the use of early coronary CTA would improve the one-year clinical outcome in patients with non-ST elevation acute coronary syndrome. The primary outcome was all-cause death, non-fatal MI, occurred in 5.8% in the CTA group and 6.1% in the standard of care group. Fewer participants in the coronary CTA group receive invasive coronary angiography, 54% of the patient, compared with 60.8% of the patient in the standard of care group. Despite fewer invasive coronary angiogram in the coronary CTA arm, the revascularization rate was no different between the two groups. Also, there were no overall differences in the term of use of a drug treatment for acute coronary syndrome or preventive treatment between the two groups. Coronary CTA was associated with longer time in the hospital. It's not shown in this slide, with a median of 0.21 day. So the latest NSTE guidelines, which was published in 2014, predate most of these trials, have assigned a Class 2A recommendation for the use of coronary CTA in evaluating patients with possible acute coronary syndrome, with the caveat that they have a normal ECG, normal cardiac troponin, and no known previous history of CAD. Moving on to a different population, the CABG patient. Compared to native coronary artery, bypass graft have larger luminal diameters, less calcification, and remain relatively stationary during cardiac contraction. These properties enable cardiac CTA to assess the grafts more accurately, whereas the assessment of coronary CTA in patients with prior CABG tend to be more challenging due to the severe diffuse nature of underlying CAD. There have been multiple studies evaluated the diagnostic performance of more contemporary CT equipment in the graft assessment with the excellent diagnostic performance when compared to invasive coronary angiography. The sensitivity was 90% to 100%, and specificity 92 to 100%, and negative predictive value of 98 to 100%. In addition to the patency assessment of a graft and native coronary artery, coronary CTA can actually prognosticate patient with CABG. In a study of 700 patients with a median follow-up of 73 months, patients were classified by the number of unprotected coronary territory, which was defined as significant stenosis in ungrafted native coronary artery, or significant stenosis in grafted coronary artery if the stenosis is distal to the graft insertion, or if there is a significant stenosis in both the native coronary and its graft. Regarding CV death and myocardial infarction in patients with unprotected coronary territory 0, 1, 2, and 3, the rates were 86, 84, 53, and 29% respectively. For ISR, generally coronary CTA is not recommended for patients with coronary stent due to artifact from the metallic stent struts. Also, often these patients tend to have higher atherosclerotic burden of non-stented coronary segments. In a study of 100 patients with 199 stents or stented segment, the single univariate predictor of coronary segment non-evaluability by coronary CTA was the stent diameter less than 3 millimeter. In a stent-based analysis, the sensitivity was 92%, specificity 91%, negative predictive value of 99%, positive predictive value of 60%, and the diagnostic accuracy was 91%. This meta-analysis was set to assess the diagnostic accuracy of 64 slice coronary CTA and more in detecting significant ISR. The results were pooled from 35 studies with a total of 2656 patients and 4131 stents. The pooled sensitivity was 90%, the pooled specificity was 94%, the area under the curve was 0.97. Combining anatomy and physiology, one can detect more clinically relevant ISR. In this study, the addition of coronary computed perfusion scan actually resulted in improved diagnostic rate and accuracy of coronary CTA when compared to both invasive coronary angiography and invasive ISR for detecting significant ISR. For CTO, the main obstacle in performing CTO is actually the advancement of the guide wire into occluded, often calcified segment into the right trajectory. And the vessel course of the CTO is often bent, which prevent direct visualization by invasive coronary angiography. Coronary computed tomography angiography can actually visualize non-invasively the exact vessel trajectory and the plaque calcification and predict the difficulty or success of CTO PCI. These are two validated risk score. The CT rector and the KCCT were derived from coronary CTA to predict the time efficient of guide wire crossing within 30 minutes as a surrogate for CTO difficulty before PCI. Also, coronary CTA can be used for live procedure guidance using real-time integration of three-dimensional coronary CTA with the fluoroscopic images. By creating these center lines of the vessel, this fusion technology helps the operator to view the path of the guide wire in relation to the vessel lumen and providing a live roadmap for guide wire advancement into the distal true lumen with the avoidance of the side branches and select the appropriate re-entry zone. By capitalizing on these ideas and results, the CT-CTO trial tested if pre-procedural coronary CTA would increase the success rate for CTO PCI. In this multi-center randomized trial, a total of 400 patients with CTO were randomized to receive PCI with pre-procedural coronary CTA, and they called it the coronary CTA guided group, or without coronary CTA, and they were the angiography guided group. Pre-procedure coronary CTA resulted in higher success rate with fewer numerically immediate pre-procedure complication, such as the coronary perforation and pre-procedural myocardial infarction. The success rate was more pronouncedly observed in patients who had a higher JCTO score, i.e. patient with more complex CTO. For multi-vessel coronary artery disease, coronary CTA can actually help with the heart team decisions making. In the Syntax 3 revolution, which was a randomized trial with two separate heart teams, blinded, that assessed the coronary artery disease based on coronary CTA or conventional angiography in patients with de novo left main or three-vessel CAD. A treatment recommendation of cabbage was made in 28% in the coronary CTA group and 26% in the conventional angiography group. The agreement regarding or concerning the treatment decision between the coronary CTA and the conventional angiography was high, 93%. Just a word about the radiation dose. With the advances in the coronary CTA in terms of better image quality, faster image acquisition, that was accompanied by incremental reduction in the radiation dose. In this large international multi-center radiation dose survey, they demonstrated 78% reduction in the dose length period in the last decade. This was made possible by the prospective ECG triggered technique scan, iterative image reconstruction, and reducing the tube potential. Finally, the 2021 Society of Cardiovascular Computed Tomography expert consensus recommendation for the use of coronary CTA say it is appropriate to perform coronary CTA as initial test for evaluating patient with no known CAD who present with a stable, typical, or atypical chest pain or anginal equivalent, in patient with coronary anomalies, in patient with prior CABG, particularly if graft patency or the location of lima graft is the primary objective. It is also reasonable to perform coronary CTA for evaluating patient with known CAD with a stable, typical, or atypical chest pain or anginal equivalent, patient who had non-conclusive functional stress test, if you wanted to obtain more precision regarding diagnosis and prognosis. And finally, patient with coronary stent with a stent diameter above 3 millimeter, patient with coronary stent with stent diameter less than 3 millimeter if they are located proximally, non-bifurcating, and has thin stent struts. In younger patient undergoing non-cardiac surgery, if the probability of CAD is low to intermediate, also to identify the coronary anatomy in patient with suspected dissection of the aorta. With that, thank you very much, and happy to take any questions.
Well, thank you very much. Are there any questions? Do you have any CT imager online or in the room for this talk? No?
There's no online questions yet. They may be coming in.
Okay. Well, I have a question. Being on the receiving end, it seems like there's like always trial data, specific data, and then there's real world data. Does anybody still look into like inter-observer variabilities? How much training do you need to really be as good as, it is proclaimed there? Because it seems like there's a lot of variations, right? I mean, patient might be not suitable because was obese, and then we still make diagnoses about it. And I mean, I don't think that anybody really follows these guidelines because patient shows up and the ED gets a CT, right? And then comes this inter-observability on top of that. Do we know about that at all?
Yeah. So, I mean, going through the literature, there was some data about inter-observer variability, but with the newer software techniques, this inter-observer variability have much decreased. So I'm not sure how much relevant now with the newer software it is. And the time to spend to be almost an expert in coronary CTA seems to, with the newer also software, seems to have been decreased. So you don't need that extensive training. And I don't know, Dr. Joe knows probably more.
The question was like, I think you heard it probably on that.
Partially, yeah. So inter-observer variability of accuracy, and yeah, it depends on image quality. It depends on how you define that. So per lesion, assessment of severity. If we were to define that visually, or if we were to do quantification, similar to what we do in QCA, it's quite good. So obviously with QCA, it's much more reproducible than inter-observer variability. The Society of Computed Cardiac Tomography has divided now into this CAD RADS, which is a way to standardize the reporting to. Some of these clinical coronary CTs are done by radiologists, and sometimes the translation is a little bit difficult. to what you do next. So they standardized. And that standardization has led to much more commitment. What do you see here? Do you think this is intermediate? Do you think this is severe? That necessitates additional testing, etc. So then now they're coming up with CAD RADS 2, which is an evolution of the first one. I have a question for you, Tarek, which you did a phenomenal job outlining the evidence, but it's outside of the topic that you described. You're finishing fellowship. And coronary CT is such an important tool, right? Yet, interventional cardiologists don't have the exposure that I believe should be necessary to get their hands on the software, feel comfortable with that. Look at the coronary CT, if we're going to do this up front, to plan for the PCI. How, you're finishing fellowship before to make a recommendation. If you were directing, in the future, how would you integrate that during the training?
Yeah, it's a pretty loaded question. I have a lot of thoughts about that. I'm not sure particularly to just the imaging part, but I think in the United States, there have been some talk about that, about reducing the initial steps in training, which include, for example, internal medicine to 2 years, general cardiology to 2 years, and extending maybe the final step in your training, like interventional cardiology, to 2 years instead of 1 year. And I think that will be very helpful at that stage to integrate not just the technique part of the being in the cath lab, but also knowing the imaging, how to plan your PCI, knowing your equipments and such. So I think it's as you said, I don't think we have great exposure to coronary CTA as an interventionalist, but I hope that in the future that will change.
So how would you integrate that in? It's a very good question actually, because we do it in TAVR, right? I mean, if you tell me I should use this valve, I'm still double checking that, but it's a big artery or a vessel or a valve, and it's easier, right? I mean, we probably agree in most of the measurements, and otherwise I go by yours. But in this, I see just a clinical dilemma, right? I mean, we can incorporate that in fellowships, that's not a problem. But let's say he is in the cath lab, and he has one of your colleagues sitting in the CT lab, patient comes in, and the CT colleague says, and obviously it happens, oh, there is a 50% left main, right? He goes and says, well, in fellowship with Dr. Gressel, I learned CT reading, and I disagree. So what do we do?
So I think, the CT interpretation was made, right? And based on that CT interpretation, whether or not there was CTFFR obtained or not, the patient was deemed to be symptomatic and is going to go to the cath lab. So now you're receiving that. I think, as one that reports those studies, we can do a better job into defining that better. Okay, what is the best projection that you can see that 50%? What is the level of calcification? Does that goes into the bifurcation? Do you have to, if there is an LAD and a big diagonal, are you going to compromise? What is the best projection that is going to reduce overlapping? All of those things we can do up front, or preferably, the ones that are going to be receiving that can take the data set. Oh, is a mid-LAD that they described, or proximal LAD? Let me take a look. And there has been some development into softwares that can take that CT, co-register with fluoroscopy, and as you rotate the gantry, it can show the CT exactly what it is. You can measure their stent length. So I think that tool, even in its absence, can already be leveraged. The CT information for planning for PCI, and I think, how would you integrate that to fellowship? Is 1 month enough? Some fellowships, I know, for example, Vancouver is starting to incorporate that. Some other centers that do more coronary CTs are taking some weeks, and so that they can spend. The buttonology, the understanding of the CT, and hopefully even upfront, during the fellowship training, not only at the interventional training, but at the fellowship training, you have some exposure to coronary CT, because it's going to become reality.
Well, I hope somebody hears you, because I think what happens in fellowships actually is siloing, right? So if Maddie and Tarek say, I want to be an intervention cardiologist, then in year 2, they're kicked out of everything that sounds like imaging, right? Is that still the case? Yeah. So pretty much, the imagers then say, oh no, I don't want to see you. You're going to be on that side of things, right? So if you're interested actually to learn these things, it's not happening. So then you have to go to your fellowship to get another year, which is, I think, ridiculous, right? But I think it's a long discussion with maybe ACGME or so to say, okay, you have to have the opportunity to actually do that. If you want to be interventional, you should be echo level something, right? And CT level something, because you constantly have to work with these modalities. And I think that discussion, I'm not sure if that's still happening.
Thank you for a nice presentation, and congratulations on your upcoming job.
Thank you.
A question that maybe you or others might know, and that is introduction of high sensitivity troponin. How might that have changed the specificity of both invasive and CT imaging? And because we haven't done that here yet, but it has occurred all around us. Any comment?
The only study that I was alluded during my talk is about that they found higher the report of obstructive CAD and NSTEMI in the era of regular troponin was in the 20% and less. Seems here it's about 30% in this study that I started with here. About non-obstructive CAD in the era of high sensitivity troponin is about 30%, versus when it was the older troponin assay was less than that, much less than that.
Yeah, some of the more recent data, mostly from Edinburgh and the group from Nicholas Mills and others, using high sensitivity troponin in the emergency room as a rapid triage. I really question whether CT should be, even necessary. So, most of the historical CT-ED papers that have come out, Romy Cat and others, were in the pre-high sensitivity troponin. If we have any conclusive, any determinate high sensitivity troponin, yes, there is a role for that. But in its absence, if it is negative, obviously.
So I agree with that. But I'm just thinking, because now the abnormal range for troponin.
Yes, really.
And so, in the old days, we wouldn't even known it was there, right?
Yeah.
And so now we're doing CTs on a troponin, the high sensitivity troponin at a pretty low level. It should, I would think, the specificity of the CT test would go down, because we're doing it in people that we don't know what they have.
Yeah.
So that was helpful to hear the change that you just said. Thank you.
So there are just a couple comments in the Q&A pod. They both come from Dr. Lesser. He first of all says, thank you very much for your presentation, beautifully done. And the comment, and I think this alludes to what Dr. Gessel and Cavalcante were talking about, but there's too much variability based on training. Do you have any final comments on that concept, or does anyone have in the room have any comments on the variability of training?
For imaging probably, right? Imaging.
Correct.
I truly believe the role of CT and other imaging modalities that help us to plan and kind of optimize these patients before coming to us. I know few people that actually went and did imaging before their interventional fellowship, and they have a different eye than a lot of interventionists in terms of planning, in terms of what do they expect during the catheterization, and how to optimize things.
Yeah, it's not emphasized. We still, have some historical, lots of months of echo, lots of months of nuclear, lots of months of cath lab during general fellowship. That's the standard, right? That's the backbone. And sometimes, CT or MR comes as a vacation elective, and then, you do a couple weeks and then you check that box off. Lots of places we don't have that opportunity. Here we are, an outlier in the sense that, fellows finish their fellowship training with level 2, level 3, right, John? It's incredible value and volume and quality of scans. How can we make this applicable to other places that don't have that? Can they have an external fellowship or come for a month, year? is somewhat difficult. Who's going to pay for that and the licensing? But it's a matter of time, I believe, that this is going to become much more reality.
And I mean, this place is unique, but the place I, for example, worked at before is, let's say you were interested, right, and you read CTs. The radiologist would then say, okay, if you're touching my CT scans, you're going to be on call for CT, right? I mean, there's sometimes also that side of it. I mean, this is a unique place where the cardiologists read CTs. That's not everywhere, right? I mean, so it can be really crazy what happens, you know, from fellowship into your job, how you can actually use that. Yeah, sure, you can do it yourself, but once they figure this out, you know, it's like, it's a really complex. But I totally agree with Joao. It should be integrated, except for structural heart disease fellows, right? They should go, they should have it. And I hope that you could make a plan, maybe somewhat earlier in fellowship, and say, well, I'm CADing that place, but look, I need CT and maybe TE or something like that. Any other questions? All right. Well, thanks for a good talk.